Welcome to Population Health Information Technology, supporting success in rural value-based care. This session will take 25 minutes to view and is the first of 4 sessions in this series. This initial session will lay the groundwork for more detailed information and insights into the technologies that are needed and have proven successful for organizations that have been rewarded through their value-based care contracts. Our objectives in this first session are to describe the broader context of how technology supports shifting from paying for volume to paying for value as we move from a reactive to a proactive, outcomes-based healthcare system with an emphasis on improving the health of populations. We will discuss a few definitions and assumptions so that we understand some of the nuances in the terminology being used. And lastly, we will spend most of our time identifying specific technologies and provide a few vendor examples which support value-based care workflows. There are far too many value-based care technology vendors and solutions to enumerate them all in the 4 sessions of this course. The list is long and changes over time as well, so we will focus on how we think about the use of technology solutions within our systems, practices, and workflows in the context of value-based care. There may be some reference to specific vendors, both technology products or vendors that support value-based care engagement, but this does not serve as an endorsement or recommendation of those companies. You may have already heard a few terms that may be new or a bit foreign at first. Some are often used interchangeably, but to those steeped in the work of transitioning from volume to value, they have very specific and sometimes nuanced meanings. Value-based care is the concept that healthcare professionals provide care that is aimed at improving the quality of care and focusing on outcomes for their patients. This is in contrast to the long-standing fee-for-service system we are transitioning away from, where the primary financial incentive is the volume of services provided. The goal is to help individuals achieve their highest possible level of wellness and health rather than to wait to provide care when patients become ill, which is often more complex and expensive. Some have termed this as moving from a sick care system to a health care system. Value-based payment is a concept by which purchasers of healthcare, government, employers, and consumers, and payers, public and private, hold the healthcare delivery system, physicians and other providers, hospitals, etc., accountable for both quality and cost of care, a definition from the American Association of Family Physicians. Value-based payment is essentially the mechanics of aligning payment incentives to support value and outcomes rather than volume of services provided. Value-based payment models are often called alternative payment models, or APM. Under this approach, clinicians or hospitals receive incentive payments to provide high quality and cost-efficient care. You may also hear the term advanced APM, which typically means that in addition to payment incentives, there is also a potential financial penalty based on the level of risk an organization is willing to take for an assigned population. You may hear these penalties referred to as the downside risk component of a contract. Accountable care organizations, ACOs, are a common type of value-based care model. ACOs typically are made up of groups of physicians and hospitals that take responsibility for the cost and quality of care for a group of patients or individuals. If anticipated costs for assigned patients are lower than anticipated and quality benchmarks are met, savings are shared between the provider and the insurer. Regardless of the technical details, at the core of ACOs and other value-based payment models is a team-based, value-based care approach which focuses on population health. ACOs help to improve the health of their community and improve communication and collaboration between providers in different locations and different specialties. There is less duplication of tests and procedures, which lowers overall costs. For example, providers, staff, and patients in acute care settings have improved communication, which can result in lower admission rates in both the hospital and emergency department. Population health management conveys the idea that healthcare providers can optimize outcomes for an entire group of people by delivering standardized, holistic services for each patient. Population health management tools include software applications and functionality, as we'll learn more specifically in Session 2, that help us to collect, analyze, segment, and stratify the broad sets of data brought together in order to gain insights and translate these into action and interventions with patient groups and individual patients. In an article from Health IT Analytics, population health management is defined as, quote, "True population health management helps to develop a partnership between providers and the patient community built on mutual trust and effort to generate better outcomes for everyone involved in the process of care," unquote. This first session will provide an overview of the bigger picture of core technologies used in value-based care delivery models and provide higher-level context and set the stage for the following 3 sessions. Session 2 will focus on technology that helps to gain insights at the highest levels of a defined population, using population health management software, and then start to translate the outputs into the next steps in Session 3, where we'll look at patient-level care management and coordination. Session 4 will take what we've learned in Sessions 1 through 3 and knit that together in a few sample use cases. You'll see in the graphic here above Sessions 2 and 3 that we'll move from the population to the individual patient level. Beneath the graphic is a set of boxes, technologies A through E. This represents the idea that some technologies are oriented at the population level only, and others support only patient-level care. Some technologies bridge the two, such as Technology C. When we talk about population health management and the technologies that help us support value-based care, we must first acknowledge that this is not independent or isolated from the work we currently do to achieve the best possible health for the patients and populations we serve. The value-based care model simply organizes how we go about it, how we apply people, process, and technology to achieve better outcomes at lower cost, and rewards organizations that are able to accomplish this. The value-based care model focuses on achieving quality metrics and reducing costs through a contractual agreement with payers, which overlaps with the familiar triple aim goals of improving the experience of care, improving the health of populations, and reducing per capita costs of healthcare. Value-based care is intentionally designed as a pathway to achieve these goals. We also need to recognize that the healthcare system is challenged with the need to address health disparities, how people in minority and disenfranchised populations or that have lower incomes tend to experience a higher burden of disease, disability, and mortality is something that the pandemic has demonstrated in a harsh light. These disparities have existed for a long time but have received transparency and more attention during the public health emergency and events triggered by the unjust death of George Floyd in 2020 and civil discourse that has followed. We will discuss how we can address disparities in health equity in Session 2 when we cover the collection, analysis, and use of population health data. We can't talk about population health without bringing up the influence that the COVID-19 pandemic has had on the sudden need for healthcare IT solutions. Legislation to allow telehealth flexibility, for example, increased awareness of this particular HIT tool we've been trying to implement for many years, and which more recently is becoming available to the general public. Value-based care utilizes this rapid advancement of many technologies, telehealth being a prominent example, and requires learning some new tools which we'll cover. Concurrently, we recognize that even in the best of times, we are challenged with the many demands of providing healthcare, and even more so during the COVID-19 public health emergency, which we've been in for 2 years at the time these sessions are being published. While we've been reacting to the demands of the public health emergency in the near term, value-based care's goals are ultimately to shift to a proactive approach with the help of both existing and new technologies. The population-level tools of value-based care, as we'll learn, are extremely useful to understand the health of a large number of people and can be employed in a public health emergency. Healthcare information technology, or HIT, is an essential component of modern healthcare and underpins our ability to achieve the aspirations of value-based care. The movement from fee-for-service to paying for value and outcomes has been a decade-plus process and continues to be an incremental shift with many models and contracts available to provider organizations. The lessons learned by many organizations utilizing the value-based care model have been integrated into technology solutions by an increasing number of vendors over this time frame, and we are still learning what works best and what solution gaps still exist, just as we did in the years when there was a massive and swift adoption of electronic health record systems prompted by the government incentives starting in 2010. The titles of the articles on this slide, which have appeared over the last 4 to 5 years, represent just a small number of the wider coverage and attention that technology has received as part of the overall value-based care transformation efforts. Overall, they indicate that technology is a key factor, but not a panacea when it comes to implementing value-based care. You can see based on the list of articles that many of the lessons have come from ACOs, as they are one of the most common value-based care models. Starting or initiating participation in value-based care is not an easy undertaking. Organizations may lack the knowledge to take action, and it can be difficult to understand how to use data and technology solutions toward actionable interventions to improve care and simultaneously reduce costs, which on the surface appear to be opposing goals. If any of the article titles strike your interest, there are links to them in the references slide at the end of this session. Technology, whether defined as an application, software, the hardware needed to run it, or the connectivity needed to move data between physical locations, is certainly an essential ingredient for value-based care, but is not sufficient for success. It is how technology is utilized as one of the three legs of the people, process, and technology stool, where value for the organization and ultimately patients is created for value-based care success. It is the combination of these three elements that work together, no different from how an electronic healthcare record system, a lab system, financial back-end systems, or other technologies are deployed. In a few slides, we will start to break down the components of the technologies that are needed to operate in the context of value-based care. When considering how to transform your organization to a value-based care model, and perhaps join an ACO or APM, you may wish to use the philosophy of Arthur Ashe, the tennis star. Start where you are, use what you have, do what you can. In the spirit of use what you have, it's helpful to conduct a gap assessment of needed and currently owned or utilized technologies, and we'll address this type of analysis later in this session. The best perspective on what helps to implement a successful value-based care model is to look at the examples and lessons from organizations that have been experimenting with the model over the past 10 years, then look at the technology needed to support the changes that led to these successes. In the article referenced a few slides ago entitled ACOs, 4 Ways Technology Contributes to Success, 4 domains are cited in reference to achieving success in value-based care models, and we will cover how technology supports these throughout the 4 sessions of this series. We can achieve value-based care success by demonstrating quality in these 4 domains. Patient experience of care. For example, patients are given the surveys to assess quality of experience such as CAHPS, Consumer Assessment of Healthcare Providers and Systems. Care coordination and patient safety. ACOs and APMs are typically assessed based on outcome measures, including ED use, ambulatory sensitive admissions, readmissions, and others. Use of electronic health data can help ensure coordination between providers and reduction of potential duplication for prescribing or tests. Preventive health. Value-based care quality metrics often relate to provision of preventive services such as cancer screening or immunizations, or effective chronic disease management such as blood pressure control. Annual wellness visits are a key strategy to support preventive care and early identification of other care needs. Identifying at-risk populations, groups that are at higher risk of negative outcomes. Successful ACOs proactively improve population health through patient engagement and identification of patients that potentially have high cost, high acuity conditions, and providing disease management support and comprehensive care coordination. Population health management also employs best practice clinical care and reduces unnecessary or duplicative care. In effect, the work done to achieve success in these 4 categories helps support what is often called the quadruple aim, initially the triple aim with the addition of the 4th aim: improving patients' health, improving patients' experiences within the healthcare system, reducing the cost of care, and improving the experience of healthcare providers. You are probably starting to appreciate the need for technology. Clinicians and care teams need the support of technology to carry out their workflows to meet the 4 goals identified here in the quadruple aim. From the article mentioned in the previous slide, authored by Health Catalyst, a health data analytics and services company, ACOs, 4 Ways Technology Contributes to Success, the key enablers from a technology perspective are: build the data repository with an analytics platform, meaning implementing a population health analytics solution that integrates data from many sources. This provides a full, comprehensive view of and into the served population. Analyze claims data. Identify outliers, including success and failures, in order to parse out the opportunities for improvement and identifying shortcomings as well. Combine clinical, claims, and quality data to identify opportunities for improvement. This is a critical element, as the combination of the two will provide much greater insights than clinical care data alone. Bring data to the point of care. This is the translational step of taking the population-level insights and putting them into the hands of providers who work directly with the patients and the care team as well, such as care coordinators and managers, a topic addressed in Session 3. In a policy brief from RUPRI, the Rural Policy Research Institute, they cite the importance of applying technology to population health challenges. Quote, "Sophisticated data access and analytics are fundamental to population health improvement and financial risk management. All payers could improve timely and accurate data transfers to providers that identify high-need, high-cost patients, highlight preventive health and disease management opportunities, and address social determinants of health. Such data analytic capacity should not be limited to high-volume or well-resourced healthcare providers." Unquote. Healthcare information technology tools should be put into the perspective of the elements needed to manage a value-based care contract and implement it at your organization. The National Rural Health Resource Center has a toolkit available that focuses broadly on transition to value-based care. A link is included in one of the resource slides at the end. It is important to note that the healthcare technology solutions should fit into the larger context and support the overall value-based care mission and objectives. The toolkit itemizes the steps needed to transition to a value-based system. Those bullet points with an asterisk near the bottom of this slide are operational elements where technology solutions are essential. Another example of how technology is key to achieving value-based goals is the importance of accurate coding, documentation of encounters that results in the correct billing codes, which we'll touch on more in session 3. Accurate coding in EHRs and patient charts ensures that correct payments are being received to support the ACO or APM contract and the organization's overall financial health. Having accurate coding not only underpins the financial necessity of receiving appropriate payment, but the data from this effort feeds the population health management application and enables the population-level algorithms to discover patterns that enable grouping of patients for targeted interventions to improve patients' health and well-being. The 6 major steps of this circular graphic are intended to convey the continual, iterative information and learning loop that drives the health, quality, and cost improvements within a value-based care model. Each of the 6 steps are carried out through the combination of people, processes, and technology. Outside the circle are technologies that support each step. Each organization or group of organizations that cooperates under a single APM or ACO agreement will have a unique but similar set of technologies, or needed technologies, which support these steps. We'll start to organize these technologies, those listed here in the blue boxes outside the circle, and provide some context for their use in the following slides and sessions 2 and 3 of this series. Let's walk through the diagram and know that we'll cover these steps in more detail throughout the series. This is just a brief initial overview. Step 1, or Circle 1, starts with defining the population. You may be analyzing the entire population that is attributed to your value-based payment contract or some subset of patients within the larger population. Step 2 requires looking deeper into the data using analytics and finding out where gaps in care exist. In Step 3, we start to look at the set of patients that we've identified by figuring out which patients are at the highest level of risk within the chosen group. This is the step of stratifying risks. Step 4 is where we take the prioritized list of patients and conduct outreach. This is part of the proactive approach of value-based care. Step 5 is where we follow and manage individual patients on their journey through the health system and advise and guide them. Step 6 is the monitoring phase of work to determine how our interventions have impacted our patients' health. As the model and process is continual, we arrive back at Step 1 and repeat the process with some amount of frequency as the health status changes for individuals over time and patients may leave or be added to your population for various reasons. To make this work possible, value-based care requires the use of a variety of technologies that we'll cover during this series, including population health management, patient registries, patient engagement technologies, EHRs, telehealth and telemedicine, health information exchange and community information exchange, admission, discharge, and transfer alerting, remote patient monitoring, and the incorporation and use of data from many sources, including social determinants of health data covered in Session 3. This is an overly simplified view of the major components of the technology systems and applications that are key to operating a successful value-based care program, and certainly not an exhaustive list. The perspective provided here is to help us organize the various technologies available into categories to which they belong, such as EHR, population health management, how we mobilize the data, and the data sets that are available. The boxes and related technologies or data sets under the major headings is not a hard and fast method of listing these technologies, as some applications, for example, can be offered by an EHR vendor and perhaps be native to their suite of applications. They could also, alternatively, be integrated or interfaced to an EHR as they can be purchased and run as an external vendor solution and run completely independent of an EHR. We would need many slides to show all the variations or ways of organizing the technologies, and even then wouldn't be able to capture them all. At the bottom, we see the data mobility pieces that move data between the different applications. Here again, there are many ways to make this happen, and we'll get into more specifics in the upcoming sessions. In the next slide, we'll take this high-level set of technologies and think about how we translate this into a gap analysis for our own value-based care needs. This is a sample technology inventory and gap analysis created in Microsoft Excel. It is an approach that you may wish to take, and you'd need to modify this example according to your particular organization's needs. Depending on where you are in your value-based care journey, this step may be a bit premature, so put it in the back of your mind for the present time, but just be aware of the general approach suggested here. This matrix can help you look at your available technologies through the lens of what your organization may need to operate in a value-based care environment versus what it currently has. The first step is to list the technologies that you currently have in the top row and add the ones you believe you would need, gaps, as well. The list in this case starts with population analytics, part of population health management, telehealth, health information exchange, electronic healthcare record, and so on. Remember, start where you are, use what you have, do what you can. Then, in the left-hand column vertically, list the functions that are needed for workflows and tasks that you would need to conduct under an ACO or APM contract. You can then go through and tick off the boxes where technologies and needs intersect and where gaps exist. Let's shift gears for a minute and look at how one organization views value-based care technologies, including the subheading of population health management. A good resource for a review and ranking of healthcare technology is KLAS, KLAS research. This organization doesn't spell out their four-letter name. This respected and independent review organization groups a large number of technologies and services that are utilized in value-based care, and we will focus on population health management in the following slides. We've included this screenshot here to give you an idea of the wider scope and context of capabilities that are available to support value-based contracting. However, keep in mind that there are many types of value-based care contracts. We've mentioned ACO and APM as one or two of the primary familiar models. These demand different goals, measurement, and degrees of patient engagement, and thus require this broader set of technology solutions. That may not be true for your organization, and your focus and needs may be much narrower when it comes to creating a set of processes to align your organization to the needs of a particular contract. The takeaway here is to recognize that there are a broad set of solutions in the healthcare information technology and value-based care marketplace to meet the needs of organizations shifting to value-based care and the goals set forth in the value-based contracts. If you explore the KLAS website, they organize the topic of value-based care into 6 subsections, one of which is population health, which is broken down further into accountable care organization enablement services, data and analytics, health information exchange, population health management, social determinants of health, value-based care consulting, value-based care managed services. Keep in mind that this is just how KLAS organizes technology in the context of value-based care, and there are other ways to group these solutions. It's helpful just to have this and other perspectives of what's out there and available and how one leading evaluator thinks about the technologies needed for value-based care. We will touch on each of these topics in the upcoming sessions in this series. Vendors shown in this screenshot are those that were evaluated by KLAS, the consumer reports of healthcare technology and services. KLAS evaluates a broad range of health IT on an annual basis and recognizes the top vendors in their category. As in any industry, there are mergers, acquisitions, and branding changes, so the names here may change over time, but it illustrates that there are many organizations working on the problems inherent to successfully transitioning to value-based care. As the prevalence of value-based care grows, so too does the number of vendors selling applications and services. You'll note that a few of the vendors are also EHR companies, thus providing population health management solutions as part of their suite of products. Healthcare facilities that utilize one of these EHR vendors may not need to employ an independent third-party solution. You might want to check what your EHR vendor is developing with regard to population health management software and support, and also inquire if they have a partnership in place with any other population health IT vendors if they don't offer the capabilities as part of their suite of products. In the upcoming sessions in this course, you may want to consider these questions and discuss each one with your value-based care team, in the context of your value-based care participation and implementation, and in the context of how people, processes, and technology are interwoven to establish or refine workflows. What technologies do we currently use? How are we using them in the fee-for-service environment? How can we adapt them for our value-based care needs? What gaps do we have in health IT? And what capabilities do we have in hand that we are not using? What health IT would we need to acquire? Again, think about these questions and answers using the mantra, start where you are, use what you have, do what you can, and be sure to check the resource and references slides at the end of each session in this series for toolkits and articles if you'd like to take a deeper dive into many of the topics explored during this series. In this session, we have taken a broad look at the core technologies, primarily population health management, needed to support transitioning to value-based care, and the technologies needed to support engaging in value-based care contracts. Session 2 will take a closer look at population health management and what this application can enable your organization to accomplish by collecting, analyzing, and stratifying larger sets of population-level data. The content of this session is based on many articles and web-based resources, and those are available in the following slides along with resources that have not been mentioned but you may find useful. A separate PDF document is available with the slides for this session, including the reference and resource slides that follow. The following slides that you'll see briefly have active hyperlinks in the PDF to make the references and resources easy to access. Thank you for taking time to review this first of 4 sessions.